The interview. So our basic objectives in this chapter are the modification of communication and interviewing for particular needs. So an older adult, someone with hearing impairment, someone that is acutely ill, as well as cultural practices, and then to also discuss the use of an interpreter, how to work with an interpreter, how to interact with patients when an interpreter is not present, and then also a brief introduction to health literacy. So the older adult, there are some special considerations that you need to think about with older adults. They take a little more time to tell their story. You need to slow down the pace and give them time to respond. Be okay with silence, and it may take more time, even more than one visit, to get the entire story from an older adult. We also want to always be respectful of older adults. They, in general, prefer to be addressed by their last name. It's not a good idea to go into someone's room and call them honey or sweetie, or immediately call someone by their first name. That's considered disrespectful, especially by the older generation. It's important to consider physical limitations. Is the patient in a wheelchair? Do they have hearing impairments, vision impairments? And to consider those as you communicate with the older adult. And then understand that touch is an important part of caring for an older adult. They may have issues with other senses, with their vision or their hearing, but touch is something that communicates a sense of empathy and kind of grounds them in reality. So touch is very important. Here's some important things to remember for specific special needs. Hearing impaired people, it's important to ask them how they communicate. There are differences. Some will communicate with sign language and require an interpreter. Some hearing impaired people read lips. They may use a hearing aid. There's lots of different communication methods. For someone that is acutely ill, it's important that we focus on the problem at the moment, and we use questions and we assess that particular problem. It's very problem focused, and that later, when they're not in pain, when they're not having trouble breathing, that's when we can get more of a full picture of their health history. People under the influence, it's important that we find out what they've been taking, when, and how much, but also that we maintain a non-threatening attitude and avoid confrontation. If a patient starts to ask personal questions about you, just remember that the interview is to get information on the patient, that both of you are there to get information about the patient, and it's not about you as the provider, and just to redirect the conversation back to the purpose of the interview, which is to get data about that patient. Sexually aggressive people, really important to emphasize that behavior is not acceptable, and even to that you may need to remove yourself from the room if the patient can't stop that behavior. Crying, anger, anxiety, those are all common responses to illness, and basically we're going to deal with those issues. That's where the patient is right then, and we're going to let them cry, let them be angry, and deal with their anger. Allow them to be anxious, understand that those are all fairly normal responses to a health crisis. A threat of violence, you want to keep talking to the patient, calmly, really do anything you can to diffuse the situation. If you can, call an emergency number, 911, and let the police or the security people let them know about the threat, and ask questions so that you can get as many specifics as possible. And then culture and genetics. Understand that different cultures have different views of genders, appropriate roles, the way that male and females interact. In some cultures, it may be inappropriate for a healthcare provider of the opposite sex to be alone in a room with a patient. So, a male provider would need to have a family member of the patient present during the physical exam. Also understand that you are going to encounter patients that have a different sexual orientation than you do. And there have been a lot of changes in state and federal laws that encourage things to be changed, like forms. They've moved from asking about marital status to asking about partners or significant others to get more accurate data on patients of a different sexual orientation. And Table 3.6 and 3.7 talk about working with an interpreter, and I would encourage you to look at those tables in your book. They have some really good tips on using interpreters. Things like when you have an interpreter, you as the healthcare provider are still going to speak directly to the patient. You're still going to face the patient, address your questions to the patient. You want to just speak a few sentences at a time to give the interpreter time to interpret your questions and to allow the patient to answer back. You want to avoid using family members or friends. You really want someone that is trained, that has some medical training to get the most accurate interpretation of what you're saying. Any interpreter also needs to be aware of the patient's culture, because that is going to help them in accurately interpreting what you're saying to the patient and what the patient is saying to you. There are going to be times when you don't have an interpreter available, and in those instances you may have to use pictures. You may have to use any words that you know in the language of the patient. You may have to use more nonverbal behaviors, speak slowly. There's certainly going to be some times that you have to communicate without words, without knowing the patient's language. And then health literacy is the last thing I want to talk about. Health literacy is something that's come up, seems fairly recently, but patients are not able to navigate the healthcare system. They're not understanding how to take their medications correctly or communicate concerns with the healthcare provider. And there's a lot of reasons for that. One of them is, obviously a patient that has a lower education level or is not good at reading or cannot read is going to have difficulty with health literacy, even though it's more than just reading. There are some tools in your book that help determine literacy, but one of the things that many hospitals ask on admission is what is your highest level of education, and that gives an okay indicator of where the patient's literacy skills, what level they're at. So some things that you can do, on page 47, there's some examples of some phrases to use and not to use, but the most important thing is to keep it simple and short, to try to avoid the use of medical terms if possible. Any written materials should be at the 5th grade level or below, and making sure that the patient has an opportunity to ask questions, to bring up any concerns is really important in increasing the health literacy of your patients and ensuring that the directions, the information about health, the information about medications is understood.